Awesome. So, welcome everyone to our April Sunday conversation presented by the Massachusetts ME, CFS, and FM Association, also known as Mass ME. I'd like to extend a special welcome to our Mass ME members. Your membership makes it possible for the organization to host and sustain these Sunday conversations, support groups, patient services, and more. If you'd like to learn more about how membership helps the organization or to become a member yourself, please visit our website at massmecfs.org/join. For our speaker today, I'd like to introduce Sallie Rediske, MPT. She's a physical therapist and a patient advocate specializing in the management of complex chronic conditions. She graduated from Old Dominion University with a Master's of Physical Therapy degree and later earned National Board Certification in Women's Health Physical Therapy. From 2003 to 2018, she owned and operated a private practice in Homer, Alaska, focusing on patients with hypermobile Ehlers-Danlos Syndrome, or hEDS, and other multisystemic disorders. As both a clinician and someone living with ME/CFS, hEDS, mast cell activation syndrome, or MCAS, postural orthostatic tachycardia syndrome, or POTS, and other comorbid conditions, Sallie's work is informed by lived experience and scientific rigor. Her clinical and advocacy efforts focus on increasing understanding of the functional challenges posed by those conditions and promoting practical, patient-centered strategies for daily management. So we welcome you, Sallie, and thank you so much for presenting for us today. And the floor is yours.
Thank you. It's great to be here. Thanks to everybody for joining in. And those are my two little rescue pups there in the picture. They're 18 years old and they're below me on the floor and they're snoring. So if you hear weird noises coming from the screen, it's them snoring. So on to the first picture. So the title gives you an idea of what we're going to talk about. Many of us with ME also face other symptoms from many other conditions, and it makes it feel like, to this way I've always thought of it, it feels like we're untangling a big knotted up rope. And in exploring the links between ME and hypermobile Ehlers-Danlos syndrome, or hEDS, I'm going to share tips for self-management and for talking with your healthcare providers about how to maybe manage things better. When we look at research on ME and hEDS, and especially where they overlap, it's very, very limited information that's out there, and it rarely includes anybody that is more involved than the mildest forms of patient situations. And so for the majority of us, it's just a big guessing game about how to manage these conditions. So what I want to do is offer some practical insights based on patient experiences and also on science that crosses a bunch of different genre of scientific study. Next slide. So hypermobile Ehlers-Danlos syndrome is a connective tissue disorder, and connective tissue is often called CT, so I'm going to use that term. And connective tissue, or CT, is the body's most common tissue, and it's made up of proteins like collagen and elastin, and it supports organs and bones and is involved in wound healing, among other things. And the top slide there, the top picture, is a microscopic image of what's called loose irregular connective tissue, and that's what holds our organs in place, and that's the most abundant connective tissue in our bodies. And those dark spots are actually fibroblasts, which secrete more connective tissue proteins, which make more connective tissue. And then the dark spots, some of them are also mast cells, which are involved in the immune response. And the immune response from mast cells is another way that hypermobile Ehlers-Danlos and ME are entangled. Both of them have very high rates of the mast cell overactivity, and this can end up resulting in headaches, gastrointestinal issues, urinary tract and urinary problems, dysautonomia, joint pain, among other symptoms. And then the last slide is an example of it's called dense regular connective tissue, and that's what our ligaments and tendons look like in hypermobile Ehlers-Danlos syndrome. So next slide. So we're not going to go deep into the diagnosis of how ME is diagnosed, but just really where it overlaps with hypermobile Ehlers-Danlos. And this slide shows the 2015 Institute of Medicine's diagnostic criteria. And we're going to pay particular attention to the first items in red. So the impairment of normal function accompanied by fatigue lasting more than 6 months and post-exertional malaise or PEM. And so I call PEM a light bulb term down there at the bottom. And I say it's a light bulb term because it's a key to understanding ME. And so the problem here, this is foundational for this presentation, is that in the hEDS world and the hEDS literature, they use the first bulleted point up there at the top to define, it's what is used very often to describe and define what is meant by chronic fatigue in hypermobile Ehlers-Danlos. So they're using a term that's been established by the IOM for ME. That's fine, but that's what they use. But then they continue to apply the idea that chronic fatigue is the main feature of ME, when actually post-exertional malaise is the hallmark feature of ME/CFS. And so this creates a real problem because we're not looking at the same thing. We're not using the diagnostic information the accurate and the correct way. So it's really important to see that simple fatigue is different from PEM, and PEM is the worsening of symptoms after physical, cognitive, emotional, sensory, or orthostatic stress. It's not just simply after an exposure to an activity, and then you have general fatigue. And it's really important that we understand this crucial difference, not only for the rest of this presentation, but really to be able to identify and to select proper management for both ME and if you also have hEDS. Next slide. So we're not going to go really deep into the diagnostics of hEDS either because it's pretty complicated actually, and you need somebody that can do a good job with this, but this gives you an idea. So hypermobile Ehlers-Danlos is a spectrum disorder, and it is on the same spectrum as hypermobile spectrum disorder. And the only difference between these two is that one qualifies for the more rigid diagnostic criteria that were set forth in 2017. And these diagnostic criteria are there on the page in the QR code and the hyperlink. So you can look at the whole page that has all the criteria listed. There are three key features that both hEDS and hypermobile spectrum disorder have. And the three key features are, the first one is joint hypermobility. So this simply just means that the joints throughout the body have more than normal range of motion. And the second one is that the joints feel unstable. So the instability means that it is either a real or a perceived sense of looseness at the joints. And then the third one is chronic pain. So because of my own energy issues, I'm going to use hEDS to refer to this whole spectrum thing. So bear with me. Sorry, I can't use both terms, but I'll wear out by the time the presentation's over from using that many words. So hEDS is the most common of 13 different kinds of Ehlers-Danlos syndrome, but it makes up 80 to 90% of the cases that exist. Many people are familiar with the Beighton score, which is there at the top of the page, and that part of the diagnostic criteria is screening for the generalized joint hypermobility. So it's screening for one part of the key features. And then the other parts of the screening tool assess for instability and pain. And then there's some additional signs that show up on the criteria, including soft, stretchy skin, frequent hernias, and other issues like pelvic organ prolapse. Next slide. So ME and hEDS are very complicated in how they relate. Um, so they also are tied together by issues like upper cervical instability and tethered cord and venous congestion syndromes. The word cloud here shows how symptoms overlap. So the blue stands for ME symptoms, the purple stands for hypermobile Ehlers-Danlos syndrome symptoms, and the orange stands for shared symptoms. So you can see how complex this is right there. hEDS affects around 111,000 people in the US, with another 580,000 being affected by hypermobile spectrum disorder, making hEDS and HSD a rare disease in the United States. But in contrast, ME, recent counts have estimated upwards of 9 million people having ME. So it's the most common unrecognized disease. Estimates run anywhere from 15% to 60% of people having ME and hEDS. And these numbers are incredibly varied in part because of the difficulty of getting an actual diagnosis of hEDS versus a spectral diagnosis that is HSD. So they're not able to actually get a clean diagnosis of hEDS, but they know that the person's hypermobile, so they can't quite come up with the specific percentage. They do know, though, that people who have ME and hEDS tend to have more severe symptoms and higher impairment, and the conditions make each other condition worse. Next slide. So that first key condition, joint laxity. So we have compensations for this. So joint laxity and instability in hEDS affects proprioception. And proprioception is your sense of body position in space, or you can kind of think of it like your body's GPS. And people often rely on end range joint positions, like there in that first picture, to get what I call a hard read on where they are in space. And this is how an example would be like how it feels to close a door when you have your eyes closed. And when you feel the door close all the way and you feel the hard shut and you hear it, you know the door is closed. But then if you tried to close the door with your eyes closed 3 3/4 inches, you are not going to be able to know exactly if you managed to get that exact distance right. And so the hard feel of shutting that door is what gives you that feedback. And that's similar to what's happening there at that joint. The person knows where their thumb is because of that hard position. So second picture is that people may hang on their ligaments for stability. And this shows a person hanging in a front to back position. And the consequences of being upright in gravity when you have an unstable system due to joint laxity, or when you have a fatiguing illness like ME, that can lead to this. And it can also lead to postural compensations like leaning or shifting weight to one side for stability, or like the last photo, where you tightly wrap your limbs around one another to create a sense of internal and external stability. So that person sitting there with their legs all wrapped around one another. So the next slide. So compensations are the brain's workarounds. And but compensations always come with consequences. And in hEDS, relying on excessive joint motion may help temporarily, but they always lead ultimately to pain, inflammation, nerve issues, and long-term damage, even including sometimes arthritis and muscle imbalances. So end range joint positions like this picture where the person has these hyperextended knees can compress vessels and strain nerves, affecting circulation and even nerve signaling. And over time, the brain adapts to these habitual positions, becoming less adaptable to variable positions that you might end up needing to move into. Next slide. So when we talked about the three key parts of hypermobile Ehlers-Danlos, we talked about hypermobility, but the hypermobility is generalized in hEDS. So that means that it affects all the joints, including the upper cervical. So that would be right up here. And this is called the craniocervical junction, or it's where the skull meets the spine. It's also called the upper cervical spine. So the skull has a hole in the bottom of it, and that's called the foramen magnum. And this is where the brainstem passes through. And right underneath the skull is C1. And sometimes you'll see the skull is written as it's sometimes called the occiput. It's sometimes called C0. And then C1 is here, and it's often called the Atlas. And the Atlas gets its name because it's like the Greek god Atlas holding up the heavens. And then C2 is below that, and that's called the axis. And the axis has a pointy projection on it, and that creates a pivot point for rotation. And some really important ligaments attach to that point and then are span out through that structure of C0, C1, and C2 and help control the stability of that region. You can see in the dark photo, the MRI, it's outlined in red. That's the skeletal bones. And very up at the very tip top, there's an arrow, and that's pointing to the dens. That's that pointy projection. And right behind that is the brainstem. So genetic factors like illness or trauma, toxins, mold is a good one, can weaken ligaments that connect the skull, C1 and C2. And if these become too lax, then you end up having issues potentially with compression of the brainstem, kinking, and you can disrupt basic functions that pass through or that occur in the brainstem, like breathing, regulation of the heart rate, and nervous system signaling. And what I always think of in this whole area is I call this the high rent district of Manhattan. So it's the most expensive urban property where big business deals are made. And due to the tightly packed real estate in this area, the most important information that goes on through there is transmitted up and down through there, and instability of any kind disproportionately impacts the entire body. So this is a really delicate area that can be destabilized very easily. Next slide. So upper cervical instability, or UCI, is most often presents in people with Ehlers-Danlos, hypermobile Ehlers-Danlos, as vertical instability, so or cranial settling, so the pressure down on the head, and it can cause symptoms like a bobble-headed sensation, neck clunking, throat tightness, or travel anxiety, and overlapping symptoms with ME and hEDS and tethered cord, and also venous congestion syndromes like dysautonomia, gastrointestinal issues, brain fog, and other symptoms make this a really, really complicated diagnostic mess, really, to work through. So diagnosis of upper cervical instability involves upright imaging, which you might use a motion X-ray or an upright MRI or both, and then careful trials with bracing or traction. And conservative management is always sought first, or preferred at least. And they usually use soft or rigid neck braces, including the Miami J or the Aspen Vista, and specialized physical therapy with whole body coordinated motions and stabilization without aggravating the neck. And then surgery is a last resort because you're risking some immune response due to the insertion of hardware into the upper cervical region. and you're definitely going to be dealing with some loss of motion at this level. And most surgeons nowadays are definitely examining for and treating tethered cord syndrome first, as they realize that untethering may relieve upper cervical instability symptoms, or upper cervical like symptoms, and not necessarily upper cervical symptoms, but the tethered cord can produce symptoms that mimic upper cervical instability symptoms. And because the tethered cord surgery is considered a less invasive and less risky procedure, it's better to start there. There's also some emerging evidence that supports screening for venous congestion syndromes before upper cervical surgery too. Next slide. So with regard to tethered cord syndrome, about 7% of people with hEDS are diagnosed with tethered cord syndrome, although the actual rates are really hard to pin down because it's difficult to diagnose. And tethered cord syndrome involves an abnormally tight, fatty, or low attached phylum terminale, which is the end of the cord. And the phylum is there, they believe, to provide shock absorption to the cord. And everybody's cord is attached. It's just that this pathological change occurs in people and it becomes stiff and rigid so that it loses shock absorption capability. And people who have tethered cord syndrome often compensate by doing things like toe walking, or they self-select and wear heeled shoes to take the pressure off the spinal cord, or they find themselves slouching, or they might develop a scoliotic curve. The triad of tethered cord syndrome symptoms includes low back pain, neurogenic bladder, which means either urinary retention or urinary incontinence, and then leg weakness or numbness. But there's almost nobody that you hear of that has only those three symptoms. They usually have a laundry list of symptoms. And with hEDS, tethered cord, one of the ideas behind it is that because the connective tissue is lax, that the upright positioning of the person, it pulls on the cord and stretches the cord due to the connective tissue laxity. And that creates an immune reaction in the cord and in the phylum terminale, and the phylum then reacts to the inflammation and gets stiff. So just by having that stretch on that lax tissue causes it. Another idea they think is that the phylum actually calcifies due to overuse, mechanical overuse. And a third one is that there's indication that there's poor drainage of the the blood that's in the veins around the phylum. And so there's not good oxygen blood coming into the area, and the phylum gets stiff and loses its shock absorption. So surgery aims to relieve this tension, and then when you relieve the tension, the neurological symptoms should improve. And there's a milder surgery which is called a simple phylum lysis. And a lysis just means that you're cutting through something. So they just cut through the phylum and take the tension off. And then there's an excision. And what the excision does is they will remove a small portion of the bone to be able to get into the spinal cord, and they'll excise or completely remove the part of the phylum. And then sometimes they will decide that they need to stabilize that segment of the spinal cord, and they will do a fusion. So they'll take two segments of the spinal cord, spinal bones, and make them solid together so that there's more stability. So some surgeons also will do this. They will do a tethered cord and upper cervical instability surgery at the same time. And this can be tricky because you don't know what surgery did what for you when you come out of it and when you recover. And you also have a really complicated recovery. So there are reasons that people do this, and it's not for anybody to tell someone to do one or the other. It's just something to think about if you were to ever find yourself in that situation. You want to do it thoughtfully. Next slide. So we've untangled hEDS and ME with the idea that we know now that PEM related fatigue is not general chronic fatigue. That's really important to understand. Now we need to know for managing um, them together that we need to understand the types of pacing that exist and which one works best for what. So the first type of pacing is everyday pacing that works for a healthy person. And that's just when you're busy and you're trying to make it through the whole week with your busy life. And that's what a normal healthy person does. And the second type of pacing is what we call recovery pacing. And this is used after an illness or surgery. And in this type, adequate rest and a reasonable amount of activity lead to improved tolerance to activity. And so this person has an intact metabolic system. So their energy system isn't pathological or messed up. And this is actually what's recommended for people with hEDS. The third is pacing for PEM. And this is what is recommended for people with ME and people with long COVID with PEM. And this is where the metabolic system is impaired. So they know with ME and long COVID with PEM that the metabolic system, the energy system is broken. Okay. So when you exercise and when you do too much activity, it doesn't make you feel more energetic. It doesn't restore your body like it does for people over time that do exercise. So this type of pacing is not goal driven, but it's actually responsive to how your activity affects your body during the activity itself, and then how it feels later after the activity, and across all those different domains of like physical, mental, social, emotional, and sensory domains. And the if you're confusing PEM with post-exertional fatigue, then you can actually it can lead to poor symptom management, meaning that you could end up creating unnecessary symptoms for yourself. And if you're new to all of this and you don't know if you have hEDS, but you kind of suspect you might, and you've been trying different things, take this little test at the bottom of this page. And it's two simple questions, but it works really well to screen for PEM. And you may find that you might need to be pacing for PEM instead of doing recovery or therapeutic pacing, the second option there. And you might find that you get some improved symptom relief, like maybe your GI symptoms improve, maybe your brain fog lessens, maybe your sleep gets better, maybe your pain levels drop. So that's a really important way this works out. And then there over on the other side is a link to a really great paper that Workwell puts out called the PEM Time Course that I highly recommend. Next slide. So this is just a photo that I put in because it encapsulates a lot about how I feel about living with all this stuff. And so I feel like I carry around a truckload of self-care tools, and some I use often and others are just there in case. But the only constant to this whole thing is unpredictability of when I will need to find something down there in the bottom of that pile. So I try to bring some order to this crazy pile of stuff, and knowing that in trying to apply any of these tools, it's like I'm applying a one person science experiment to myself. And I also recognize that when I apply these things to myself, that change takes cognitive energy, and that my past responses to anything that I've used out of that truck does not always predict the future responses. So just because it worked then, or just because my response was a certain way then, does not mean I will respond that way now. So this is all to say that in pacing for PEM, you start low and slow and then go even slower. And the ideas that I'm going to suggest now, they won't work for everyone, but many of them can be adapted and they might jog your memory or thoughts about some other ideas that you might be able to apply. Next slide. So a few more light bulb terms before we dive into the management ideas. So all activities, physical or cognitive, use energy. So exercise is just a formal activity for fitness. That's all it is. So for people with ME, prioritizing your activities of daily living, that's what we call them in therapy world, is ADLs. And that's stuff like eating, bathing, and toileting. And then instrumental activities of daily living, which is stuff like cooking, shopping, and financing, is more important than exercise. So activity is a sub is exercise is a subset of activity. Okay. And then graded exercise therapy, or GET, sets fixed goals for intensity, duration, or frequency, regardless of your symptoms, even if only one of those, frequency, duration, or intensity, is the only thing that is predetermined. It is still GET. Do not let anybody tell you otherwise. So for ME, the plans must follow your symptoms, not the other way around. And then GET, increasingly, we're seeing this happen where people are using these euphemistic terms for GET, such as progressive exercise or progressive activities or graded activities. So those are all GET. They just are changing the word so that it doesn't fall under that dreaded term of graded exercise therapy. And then in hEDS, CBT, or cognitive behavioral therapy, often targets kinesiophobia. And kinesiophobia means the fear of movement. And in this case, for people with hEDS, it's usually because they're afraid because of their instability or their feeling of instability. While in ME, if there is fear, it's because they're afraid they're going to trigger PIM. So going back again to what we were talking about earlier, if you screen for PIM, then it actually helps tailor the right approach. Because if you're treating somebody with CBT and you're treating them for the wrong problem, then it's kind of pointless and waste of time. So it should match the patient's needs. Okay, next one. And then here's some ideas that are kind of updates to things that most of us have grown up with or heard in the general media that can help untangle ME and hEDS. So, for instance, studies show general exercise is as effective as core stabilization, even though core stabilization is generally what's put forth as the favored approach in hEDS. And then posture is not only about one ideal position, it's about movement variety. Stability starts with brain control and bone alignment, not just muscle bulk. So you don't need to be big and beefy to create stability. Instead of only building muscle strength, hEDS management can actually focus on releasing overactive muscles to improve function. So it's not always about turning muscles on, it can be about turning muscles off. And lastly, assisted devices aren't setbacks, they're tools that reduce fatigue and support better body mechanics. Next slide. So these posture tips are here to support joint balance, fluid flow, and nerve tension. And while I don't have photos of people with severe cases of ME or hEDS, the principles of alignment, support, and function still apply. So in the first photo, the stacked pillows push my head forward, compressing my neck, which is risky if you have upper cervical instability. So the dens, that pointy projection off of C2, if the dens were loose, I mean, if the ligament was loose, would potentially push backwards in the spinal cord and press into the brainstem. The other part of that is you can actually get compression in the internal jugular veins, cutting off blood flow out of out of the brain. And then you can also increase tension on the tethered cord by rounding the head like that. So this could increase a bunch of symptoms from sensation and movement changes to anxiety and even blackouts. So the second photo shows an improved alignment with support through my whole spine from my low back and hips. And then I've got on a pair of prism, not prison, but prism glasses, and that are allowing me to look forward without tipping my head down. And then just look at how my neck is open and relaxed there on that second photo. Next picture. So in the next photo, you can see how she's gripping her feet. She's actually using her feet to try to create some stability. So the chair doesn't actually fit her, and she's trying to create some stability with her toes. Another way people do this is they'll wrap their feet around chair legs. And so what we did in the second photo was we used books to bring her feet, bring the floor up to her feet. And that took some weight off the back of her legs, so potentially increasing um, the back fluid flow up the back of her leg. And it also caused her to shift backwards, which then put her head over her trunk skeleton. So she was bearing weight more over her skeleton. We also put books under her forearms. And if you've noticed, most people barely make it any amount of time in a chair with armrest before they slouch over because armrests never fit anybody. And people who have lax tissue, this huge, heavy shoulder girdle is suspended off these delicate neck bones and it hangs. And so all this nerve tension, all this fluid flow is being strained by this heavy weight of this shoulder girdle. So one thing to think about, a lot of people don't think about, is you can have a tight muscle because it's tight and short, but you can also have a muscle be tight because it's tight and long, like a muscle that's like a rubber band that's going to pop. So what we did there was we elevated her arms to the point where her shoulders were no longer tight, being stretched long, and that took the strain off of her neck. And that was what she reported was her neck felt the most relief. And once you find what works, then you can kind of make it semi-permanent with some duct tape. And you can also mimic this on your sofa or bed with some firm pillows under your arm. Next slide. And then in wheelchairs, kind of the same sort of idea. So a lot of times people sit with their knees falling out or their knees falling in, but we want to shoot for that third picture with the hips, knees, and feet lined up because even weak hip muscles can strongly influence leg position. And so then when you go to stand or lie down, it can pull on the pelvis and the low back. And this can, just this little tiny adjustment in the third picture can help retrain the brain and support muscle balance and mobility. Next picture. So people with hypermobile Ehlers-Danlos syndrome stand frequently with their heads tilted back, and they have a bunch of ideas about why, but one of the ideas that they believe strongly is that it's due to the altered proprioception that we talked about earlier as a compensation. So you can see in the first photo, her knees are hyperextended, so they're locked. And you can see the compression in her back. The angles there in red are pretty sharp, and her chest is downward sloped, and her shoulders are rolled forward. And then the only instruction that she got was to unlock her knees. And what happened was this body-wide shift that caused her to elongate her the curves in her low back and her neck, and her arms, her shoulder girdle opened up, her chest lifted, and her head moved back over her shoulders. And her comment was she felt more open and she felt like she could take a full breath. So just this small change made a body-wide shift. So one of the things I would recommend if you try this is do just ever so slight, unlock your knees and then let it go and do that for a little while and then practice, maybe doing a single functional task that you might be doing in standing anyway. And just make sure you're not stirring up PIM. And then the other thing you can do to kind of train your brain that this is a good idea is do before and after photos, or you can also say what your symptoms are in the first photo and then talk out loud and tell yourself what your symptoms are in the second photo. So your brain understands that, oh, this is a good change, and internalize these changes. Next photo, or yeah, next slide. So we had earlier the front to back hanging on your ligaments. This is the side to side hanging on your ligaments. So she's standing on her right leg, and it's probably her habitual position. So they know that in hEDS, asymmetry may actually be more harmful than general hypermobility for the stability of the pelvis and the hip. So becoming aware of patterns like this may be really important for people with hEDS, and simply just practicing and catching yourself, keeping your weight shifted to the center, or occasionally just shifting, in her case, off to the left side would be helpful. And then the second photo shows sidestepping upstairs, which is just a really gentle way to exercise the hip muscles on the outside of the hip. And it's another way to challenge your coordination. And it's also good for people who have fear, or both real and perceived, about kneecap instability. Next slide. And then this one is a tricky one, but it's worth practicing. So it's called a neutral spine squat. And you want to start in sitting, um, and you want to hinge at your hip. And so in the first photo, you can see where she's bending at the hip. So it's way down at your butt, not up at your waistline where your pants button. And she's got her ear, her shoulder, and her hip lined up. And so then you would just practice rocking back and forth for a little while. And the beauty of this particular move is because it can it can it helps with it teaches you to move without getting stiff and rigid while you move. In order to do this, you have to stay kind of fluid. So it helps with balance, it helps with coordination. You're bearing your whole body weight, so it's a good strengthener, and it also makes our nervous system glide. So once you've done it in sitting for a while, then you can try it in standing. So you're going to unlock your knees, and then you're going to go do the exact same thing. Bend at the hips, keep your spine straight, and you notice your spine starts really where that hip hinge is, and it goes all the way up to the ears. So she's not looking at the horizon. She's not looking up. She's keeping her neck long, and she's keeping her knees behind her toes, and her weight is in her heels as she goes down. And then when we look at her from the front, what's happening is she's stopping before her knees fall in or her knees fall out. And so this position, which I would call it a partial squat, is a completely functional position for maybe changing the trash can liner, or maybe putting a dish in the dishwasher, or spitting in the sink after you've brushed your teeth. So she could practice that and get really good at that. And then if she wants to learn to go a little bit deeper, she can. And then the third photo is me showing how you can use the hip hinge. So the deeper you bend at the hip, the more control you have in how gently you can sit down on a seat like the toilet or a chair. And then when you come out of it, you bend forward from the hip, and that creates a counterweight to lift your bottom up. And then you press through your feet to come up to standing. Next slide. So these tools support joint stability and reduce strain. So blanket support keeps the weight off the feet and ankles, and structured shoes like these slippers with this kind of firm heel cup can help people from ending up with their feet pointed if they spend a lot of time in bed. And what happens over time is muscle imbalances develop where once they do try to stand up, either they can't get their heel down or they can get their heel down, but their arch collapses in order for that to happen. So that's a really nice thing to do if the person can actually tolerate having a soft shoe with a little bit of a heel cup on. And then the pan splint is the last photo, and that's to help people prevent wrist curling at night. And even just a few hours at night can ease pain that will develop around the wrist bones here and protect alignment. And very often it will actually train the person to sleep in a better position. Next slide. And then insoles can help with balance and proprioception in hEDS and reduce energy use both for hEDS and NME. And you can use custom or over-the-counter versions, but you want to be very aware that they change the body from the ground up. And because of the laxity in the system, a change in one area really changes everything. And so you're changing physical, cognitive, and sensory information. And so this wearing an insole needs to actually be figured into your pacing for PEM program. Then the next picture is compression clothing and leggings and tops with this ribbing that's visible in the picture. There's different styles and kinds of it. Has been shown to improve balance and a sense of joint stability. And they're thinking that it improves, it stimulates the sensory receptors in our skin and the outer body layers. And they found it really helps with people with low vision deficits that have impacted their balance. And then lastly, they're sacroiliac belts, which you don't have to wear them on the outside of your pants like that guy. But uh, these have been shown to improve proprioception, stability, and reducing pain and fatigue. And my experience clinically was that they were best for people wearing them at night when they did not have body awareness of what they were doing with their legs. And then their muscles were relaxed. And then also to wear them in high fatigue situations during the day when they just simply couldn't control their muscles enough. Next slide. So when you've done all of this and you still figure out that there's a surgery that may bring you some um, better quality of life, here's some tips that we have. So the first thing is to really focus on mast cell care early and be aggressive with it. You want to do this to reduce inflammation and also go in with an attitude that surgery is not a cure for ME. It's to take a layer of symptoms off and to improve quality of life. And if you do that, you'll probably come out very satisfied. Continue to pace for PEM and realize that your sensitivities and your symptoms often shift after surgery. So you're going to want to stay curious and flexible after surgery, but continue to pace. And then recovery is slow. There's a lot of people who come out of surgery and they go gangbusters because they're so excited about their new life. But the rule of thumb in rehab is really that 3 to 4 days of recovery for every day of immobility. Plus, there's neurological healing that has to take place. And neurological healing is notoriously slow. So the that's the sad part is that it takes a long time. The good part is that neurological healing goes on for a long time. So you may see positive changes for a very long time and get a lot of return for the investment that you made in that one surgery. And then choose physical therapy post-surgically that respects ME and that knows the difference between PEM and chronic fatigue. That's really important. And then finally, my most recommended, least used piece of advice, use ice. It helps with inflammation and pain. And most people are averse to it because it just, it's so cold. But cover ice packs with fleece. That's a good one. And then ease into it by putting a contrasting heat source, either opposite side of the body or somewhere else on the body. Or you can even just do a little heat first and then put ice on it after you've done it for about a minute with the heat. And it will really make a difference in the long run. And then lastly, let's summarize this whole thing. So what have we, the untangling of the hEDS and ME. So PEM is not chronic fatigue. So know the difference. And ME needs pacing for PEM, no matter what other conditions exist. And ME management prioritizes daily function of ADLs and IEDLs, so eating, toileting, grocery shopping, over exercise. And hEDS management focuses on strength, motor control, and reducing fear avoidance. Assisted devices can be helpful with both conditions. And then the integrated approach for ME and hEDS is pacing for PEM, consider functional tasks as a precursor to exercise, and then support weight bearing through the skeleton when you can do that, and include varied movements when possible. And then we have, I hope, time for questions.
Wonderful, Sally. Thank you so much for that presentation. I'm always glad we record these, but the specifics on some of these images are so concrete for people to be able to reference later. And we got a lot of comments, already appreciating their value and stuff.
Good.
Um, we definitely can take some time for questions. For those in the audience, we normally run until about 5, and since Sally had a wonderful presentation, she is able to stay a little bit after. So we're going to take as many questions as we can, probably up until the 5:15, 5:20 mark, and then go through our final closing remarks and updates on our next presentation here at Sunday Conversations. So to kick us off, Sally, I have one question to start.
Sure.
Um, how do conditions like MCAS and POTS modify kind of the rehabilitation options or physical activity guidelines for these people who have both ME, CFS, and hEDS?
Um, Almost always the bottom line is that the pacing for PIM has to be the bottom line. Um, that has to be managed first. Every now and then you'll see somebody who has to have additional um, targeted care because of the level of involvement of MCAS or POTS as the driver of these of like their ME symptoms. But I don't know that I've ever heard of somebody um that can, you can manage their POTS and then disregard the PEM. So that's you've got to manage the PEM first, the energy part first.
That makes sense based on the other stuff you described in your presentation as
Yeah.
well. Thank you for clarifying that. Um, One of our other questions from the audience is any advice for finding, or resource, I should say more specifically, for finding providers, doctors, physical therapists that are really familiar with these conditions? People just describing a lot of struggle in finding people who are aware and more knowledgeable, you're coming to them for help.
Yeah. Um, yeah, if there's it's a really, really lonely place out there, just like, every time we look for a doctor, for anything. But there's a group that we have um uh PT, speech resources for treating ME/CFS. And if you are needing somebody who's, you're needing one of those providers, if you'll message me, then I can look in our group and see if there's anybody. Um, and that would be the quickest way. The other things, there's a few key features that I um look for when I do a search myself, looking for somebody, for someone. And I definitely look for things like people that advertise that they treat chronic fatigue on their web page, so they might have a whole bunch um, of different kinds of disorders and diseases that they treat, and they list chronic fatigue. I don't go to those people at all because those people almost without fail are going to come at the issue as a functional medicine approach and as a functional neurological disorder approach. And so that's a telltale sign that uh, they lump everybody in that category into that.
Okay, great. I'm sure that will be helpful for people searching on their own, and we have your contact information as well for
Yeah.
searching within that network. Um, Another question we had from the audience is asking how any sensory sensitivities might be related or manifest in hEDS.
Yeah, so the sensory issues, so there's a lot of really interesting work done. We talked about proprioception a lot, so your body's GPS. But one of the things that they, like when I was in school, they didn't talk about the skin as part of the proprioceptive system.
Mm.
And really, the technical terms should be the somatosensory sense system. And so there's this phenomenal network. Like if, I mean, you can actually think of it like a net that goes over our body that's made up of cells. And so because our connective tissue is different and is looser than it should be, the tone that's in that somatosensory net that's stretched over is think of it like a giant pantyhose, that fits us. Um, it's too loose. And so when the information hits it, it doesn't get the right signal. And so it either reads it as, too much input or too little input. And so that's a lot of what we're feeling is coming through, this. And it's the biggest sensory organ in our body. And so I think they're only beginning to tap the awareness of how much that plays into things. And so I think some of the things that, going back to therapists, some of the therapists that do have really good results with patients are people that do really skilled, gentle myofascial work
Mm.
because they work in that plane, in that level, and they're releasing the tension and helping that um, blood get into that layer better, and it makes people feel better.
That makes a lot of sense, understanding the, biology as you've described it, and the more we know about the
Yeah.
skin and everything, that certainly makes sense that something like myofascial would help access that area and kind of make them talk to each other.
Yeah.
I know you reviewed a lot in your photos at home, setups and things, and some of those included things like braces, other devices. Do you have any suggestions for braces that can help with the forward head posture in upper cervical instability?
Um, yeah, it's a really, really hard thing to address. So this was one thing that I didn't put into the presentation because it's kind of like a little dog leg off to the side. So there's one of the things that I would say is that, so I had this couple slides where I had the young woman that unlocked her knees and she got taller. Well, one of the things I would say is that if you try that and it doesn't feel good, or you try it and you just like there's just something beyond um your cognition that's not letting you do that. What I've learned with this illness is that when something is just not right. And in my personal case is I found that I was doing all kinds of things to try to correct my upper back and my upper neck alignment. And I was fighting my tethered cord is what I was doing.
Mm.
So so if somebody's really finding that they cannot get that up and they've tried a rigid collar and it doesn't really do anything for them, maybe the next step should be actually to see somebody about a tethered cord syndrome issue.
That makes a lot of sense. And yeah, patients always know really what is
Yeah,
the, even if you maybe
yeah,
don't have the words to verbalize it or know that
yeah,
these forms,
yeah,
it's understandable that that might be the next course.
yeah.
We've gotten a few questions, and people kind of chiming in together, affirming but asking, can COVID infections make hEDS worse?
Yes, because any kind of, I mean, well, let me put it this way. I have not actually sat down and read any literature that does, but because there are definitely cases of infection that has been shown to do so, yes, that would be the case. So I think that, infections, toxins, antibiotics, there are antibiotics that do, and so
Okay. Yeah.
yeah.
One question that we have from the audience, I'm not familiar with this acronym, but a person is saying that they believe that doing HBOT made her more hypermobile. And have you ever heard of this happening to others?
That hyperbaric oxygen therapy, HBOT.
That could be what they use the
Um,
acronym. I'm not familiar,
yeah.
but that would make sense.
And I think I've actually heard that before. I can't I wouldn't be able to comment in an educated
Sure.
manner on that. Yeah.
Okay. Um, I know we spoke a little bit about in our first question, people who have both MECFS and hEDS and kind of where that baseline might be a best starting point. But in terms of, you mentioned in your presentation as well, GET or the graded exercise therapy. Is there any danger of overexertion for those with MECFS during standard rehabilitation, or are there any specific modifications geared at that? Or might it be more general, like you said, of finding that middle point between them as the priority to start with?
No, it's all there's always a chance. So I think that the thing is for people to really look at, first of all, it's that paradigm shift of allowing ourselves permission to understand that activity can replace exercise, and that when we have ME, that our going about our daily lives may be what has to fill in for exercise, depending on how severe you are. I mean, there are people that doesn't even happen, but um, and that, exercise, um, we may get to that point, or, you may be lucky that, you never lost that, but the problem is with most trained professionals is they are so consumed by the idea that exercise has to be in that formalized structure, and so it doesn't matter what the person has to do in their daily life, they are going to put you into some kind of formal exercise program instead of seeing the totality of what you do as an energy using event, you
Sure.
know, and that's what we have to look at. And so it doesn't matter. You look at the whole picture, as the energy use, not what is it called, you know.
Okay. Um, One other person had asked, kind of describing a situation where maybe they've gone to a physical therapist or an OT because of a specific injury, but with hEDS or MECFS, they're only getting help for maybe that specific area, but kind of down the line, it's causing more problems later or not so systemic. Is there anyone else that they should be going to for a more encompassing overview of that then?
Yeah, in my personal experience with PTs and OTs is that there tends to be a more um um there seems to be a more readily available population of therapists in the hEDS community. the ME community still is just it's just almost non-existent in the ME, I mean in the rehab world. And I think it's because we're looking at those two different types of pacing because we're asking PTs and OTs, PTs especially, to completely throw out the foundational piece of their entire training, which is to exercise somebody to get them better. And so my feeling is that, probably working with somebody that does work with hEDS, but then trying to get them to talk to somebody who really knows ME. So the therapists that work with the Bateman Horn Center Rehab Project is a good place to start. And the Bateman Horn Center medical education program is always willing to do trainings for any therapy group.
That's great to know. And that makes sense. A collaborative effort might be needed just by the nature of the field and kind of where it's coming from. Like you're saying,
Yeah,
foundational understandings maybe don't apply yet here.
yeah.
Mhm. Um, One question we also got from the chat, if you were able to comment on any regenerative medicine, excuse me, they listed things such as PRP, Prolo, or stem cell before surgery for the CCI.
Yeah, I my commenting is pretty limited. I know that I um generally it's just a delay, you know,
Okay,
yeah, that's just gotta go end up doing what you gotta do.
gotcha. You did mention those upright MRIs for
Mhm.
specific situations. What diagnostic studies might you recommend for evaluation of the UCI, and what might the findings kind of look like if it excuse me, if it indicates that?
Yeah, and that's getting out of my wheelhouse because I can't keep up with what all the different surgeons want. So some of those are going to be surgeon specific. And so that would be, depending on who is going where, what they want.
Sure.
So,
Okay. Um, One other question we had from the audience is asking if having a syringomyelia or a syrinx in your spinal cord relates to EDS at all.
mhm. Yep. And so um when we talk about tethering can, we talked about the phylum terminale, but there's also other forms of how the cord gets tethered, and those can be a way that the cord is tethered, and those are more highly correlated with um, people with hEDS or connective tissue disorder. So um, anything that shows up basically along that cord that um, creates an out pocketing that makes the mobility of the cord less than it should be, um, or where it adheres down or anything can create the tethering. So the most common is that phylum terminale at the bottom, but they see them lipomas and different things along the cord. And so that is a way that a cord can be tethered, and it is associated with hEDS.
Okay, interesting. I wasn't as familiar with the term, but also makes sense.
Yeah.
Um, One of our other questions from the audience, in terms of, physical therapy, should patients who are recovering from these surgeries, like the craniocervical fusion or the cord release, do you think it's advisable that they forego physical therapy during the recovery because of this risk of the PEM, or is it maybe more just the importance of seeing someone who is specialized in it to avoid those things? What is your opinion?
Um, no, I think it's really important to try to find somebody who is trained. The people who are trained are really good, and then the people who aren't are, like so um so one of the things that I see, like, as a, like, observing what happens is a lot of time, like, we're all so tired and we're so challenged with all the demands of of self-care anyway, because we don't have the services that we really should be given, and where most of us are self-managing our conditions anyway. And so, but one of the things I think that happens a lot of times is people will get onto like a surgery tracked, and they don't if they can slow down just enough to kind of make a bigger picture plan of like, what is this going to look like all the way through, who do I have in my wheelhouse on the other side of this, because there are some where some of these surgeons locate, there are some really good therapists, but you got to know who they are. They're
Mm.
not necessarily the ones that, talk the loudest sometimes. And you need to be able to get on their schedule, because some of them are booked up months and months and months out, and you got to figure out how to pay for them, because not
Right.
all of them do this insurance stuff. And but doing, even sometimes 3 appointments maybe with some of them can be completely transformative. And so um it's really worth kind of looking at the really big picture, and making this kind of big plan of how you're going to do this.
Sure. Circling back to one of the questions I just asked, actually, one of our comments, apparently there is no upright MRI in Massachusetts. Do you know of any neurosurgeons or other providers that might initially consider a flex or that motion X-ray that you described for diagnostic purposes?
um I thought Bolognese was taking it for a while. I don't know if he is, but I may be behind the times on him. But I think he was taking, there's the one out of Pennsylvania, but
Okay.
maybe somebody can comment um
So it's
in
a
the
good
yeah,
question amongst, we have people from a
yeah,
lot of areas, so, and I'm sure that
yeah,
varies state to state.
yeah.
We're just almost at the 5:20 mark, so I'm gonna
Great.
end with one more. Um,
Okay.
in terms of, talking about both the hEDS and ME/CFS, how much is cognitive exertion a factor, although we're talking about a lot of physical and sensory and kind of their connection, if you could speak to that at all.
Yeah, I think it varies person to person, but I will tell you that my husband used to tell me this all the time, and he's a pipe fitter, so I always thought this was really enlightening that he was the one who reminded me. He's like, "Honey, your brain takes 25% of all the oxygen in your entire body. Why are you so upset that you're tired?" You know, and so that would be on a good day, so I think it's really important that we remember that figure, and he is right. And so if you're doing something that's particularly, we might be thinking, oh, I'm lying down and I'm doing some kind of, intensely, eye brain coordinated thing, man, you are cooking up here, and it's not going to show up on your heart rate monitor.
Sure, sure. Um, yeah, it might be one that people even experience and don't know how to put the words to. With an
Exactly.
explanation like that, it is very clear that that would absolutely
Right.
cause that impact.
Yeah.
Um, thank you, Sally, for your really in-depth presentation and for answering all these questions. Your perspective really sheds a light on such an important topic, and I know people are really eager to learn about this, so we really want to thank you.
Thank you.